another story, something to get off my chest.
Hello and welcome to another Pyper pod. Today we're going to continue with pathophysiology, and this time we're going to look at the respiratory system and all the different pathophysiological states that affects the respiratory system. So it can pretty much be broken down nice and easy as a bit of a teaser into things that involve lung failure and those that involve some form of pump failure as well. But we'll get into more details as we go through. So first of all, before we move into it, we'll just remind the functions and structures of the respiratory system. Now, obviously the main function of the respiratory system is associated with gaseous exchange. Now that is done by CO2 diffusing out of the blood into the alveoli and O2 diffusing out of the alveoli into the capillaries. Now we're not going to go into too much details. If you want more information, then you can go back and look at the anatomy physiology of the respiratory system, as it will go through gaseous exchange as well as acid-base balance, where CO2 moves into the bloodstream, mixes with the water and becomes carbonic acid, and therefore can be utilized as a stabilizer for both acids and base. The last thing it does is it obviously plays a big role in the olfactory side of the house. Now, looking at the cellular structure of the bronchs through to the alveoli, we can see a lot of differences. So the main difference you'll notice is the size of the base membrane. So in the bronchus and the bronchioles is quite large. Now, as a reminder, this is the area where gaseous exchange does not occur. This is just passageways in order to get to the alveoli. Now, the bronchus itself has two areas that secrete mucus. It has the bronchial glands, and all the cellular structures within the glands will actually secrete mucus for the bronchus. It has ciliary bodies that help move the mucus around, and it also has mucus cells as well. When we get down to the bronchioles, we have ciliary cells as well, and mucus cells, and a smaller base membrane. Once we get to the alveoli itself, as you can see, the base membrane is tiny, and we start to introduce capillary flow. Now, the alveoli is made up of two specialized cellular structures called pneumocytes. Now, there's two types. There's pneumocytes type 1 and type 2. The type 1 is where the gaseous exchange occurs, and type 2 is where your actual surfactant is produced, and that's what it has. Now, living in this alveoli area, we have macrophages. So they're actually referred to as alveolar macrophages, and they're able to obviously engulf any form of pathogen that comes in, and then they can exit the alveoli through these cool little pores called the pores of Crohn's, and they allow bacteria and exudate to actually move in between the alveoli itself. Now, general symptoms that we'll find with respiratory pathophysiology is we first of all have the big three. So you have hypercapnia, hypoxemia and hypoxia. So hypercapnia is an excessive level of CO2 in the arterial blood. Hypoxemia is reduction in levels of oxygen in the arterial blood, and hypoxia is just a reduced oxygen level to the tissue. So that's the difference. So they pretty common symptoms, whether you're dealing with pump failure, you're generally looking at your hypercapnia and your hypoxemia, whereas when you have your lung failure, we have your hypoxemia and obviously hypoxia from there. Now, dyspnea is a term used to describe a shortness of breath, and that's mostly associated with the mechanical side of the house, and just anything that reduces the amount of oxygen that can get to the blood as a result of internal respiration or transport or actual external respiration as well. So all those things will give you a shortness of breath and a need to breathe more. Coughing is quite common. We have acute, like the cough I have now, it's quite acute, it only just started, and then we have our chronic. So if a chronic or persistent cough, they're usually the ones associated with a respiratory disease. Now, other features about a cough is we need to ascertain whether it's productive or non-productive. A dry, non-productive cough is generally caused by an irritation in the upper throat, whereas a productive cough can be a result of postnasal drip or can be a result of a respiratory infection. Now we can tell that by looking at the sputum as well. So different types of sputums we can get. We can get clear, which is generally a sign of irritation, like a chemical being exposed, inflammation, like what you get with asthma. If you get a pleural pus discharge, can be green, white, brown, those sort of things, then it's associated with an infection. If it looks like mucus, then that's what it is. It's mucus just coming from your sinuses. The next one is hemoptuous. Now there you're coughing up blood. So coughing up blood itself or having blood in the sputum essentially means the same thing. Now when it's bright red, that's usually associated with eroded blood vessels around the upper throat or the larynx itself, and can be a sign of a tumour invading into the actual wall. When we have frothy blood, it's associated with heart failure. Okay, so we have we'll learn right or left side of the heart depending on pre or post load. Will be associated with hemoptuous because of an increase in fluid breaking the capillaries. And dark red blood means that it's been digested, so it's actually coming from the gastrointestinal system and being coughed up at the same time, is when you'll get those dark blood. Chest pain can be difficult to ascertain when you're dealing with symptoms. It can be a result of irritation, inflammation of the pleura itself, or it can be a result of coughing spasms, therefore having fatigued muscles. It's just a matter of doing a good PQRST, finding out traits to it. Cyanosis is not as common as people think, usually associated with chronic conditions of low oxygenation, and that's obviously where you get a blue tinge around the mucus. Best place to find that is on the lips, or actually inside the lips on the mucosa. That's the first place it actually shows up. Now clubbing is something that is not really understood. It's quite poorly understood, but because of the type of people we find it in and the type of characteristics they have, it has been linked to chronic low oxygenation. And what it is a bulbous enlargement of the ends of the fingers and toes, and it looks pretty interesting when you see it first, almost like a metamorphosis into gecko for fingers, if you will. Now the common ones, respiratory ones that is, it can be caused by a lot of heart conditions as well, or sometimes a really poor perfusion to the fingers and toes as well can also cause it, but it's mostly your pulmonary fibrosis, lung cancer, and your bronchial laxitus as well that causes your clubbing. So it's one to look out for, and it generally means that someone's had a respiratory heart problem for a number of years. Alright, let's move into the actual infections themselves. So the first ones we'll look at is just generally respiratory infections. Now obviously there are thousands of these, especially when we start looking at upper respiratory tract infections, so I'm not going to cover them in these lessons at all. It's all going to be lung based in this particular lesson. But pathogenesis from infectious can occur from mostly inhalation of aerosol particles. So if you have infectious particles, you breathe it in, droplets, that sort of thing. That's the most common way of getting a respiratory infection. The other way is aspiration from the upper respiratory tract. So you start with a sore throat, you start with a rhinitis, and you breathe it in. You're breathing in that infectious state, and it goes from there. Now aspiration of gastric content is quite difficult to do, but anyone who has difficulty swallowing or loss of control of their motor movements, mostly in the elderly, they're obviously more subject to breathing in gastric contents. Now there is a way that the respiratory infection can actually come from the blood as well, just so you know. So it can start in the blood and then diffuse through the capillaries and start a respiratory infection that way, and we'll talk about a few of those as well. So the first one and the main one to look out for is your pneumonia. Now this is characterized by inflammation of the lungs, okay, or the parasitema itself as a result of an infection from microbe. Now the thing with pneumonia itself is its causes can be multiple. It can be viral, bacterial, fungi, or protozoal that can cause pneumonia itself, and it's just an invasion of the actual lung tissue by a microbe, and it causes this massive inflammatory restriction of the alveoli sac. And once the alveoli become inflamed, they get filled with inflammatory fluids or exudate that we call it. Now this exudate impairs the ventilation, impairs the gaseous exchange, and you get the dyspnea. As it builds up, your body wants to dispel it, so you cough. Now in most cases they'll be resolved, and they'll be resolved with just a general growth and the stem cell replacement. So pneumonia won't actually cause fibrosis in a lot of cases, which is very handy, because we'll talk about a few other conditions that cause fibrosis, and they're irreversible. You can never get away from that. But pneumonia, in most cases, just resolves because a large population of stem cells are present in the lungs, and they can just repair themselves, which is good. Now, the two main different types is we have our lobar pneumonia, and then you have your bronchopneumonia. Now, lobar pneumonia is where an entire segment is essentially affected, and what happens there is the outside of the alveoli sacs will actually become inflamed, and the whole thing will have a reduction in its ability to diffuse gases. So the whole alveoli sac becomes inflamed, and the whole base of the lung fills up with fluid as well. That's your lobar pneumonia. Whereas your bronchopneumonia is just small patches of consolidations that you'll find over your actual x-ray. If you look into it, it looks just like general consolidation, and only partial areas all over the lungs will be infected. Now they're often associated with your fungal pneumonias, whereas bacterial will sit in an area and be more lobar as it is. Another type of pneumonia that you can get is your interstitial pneumonia. Now this is different because instead of having inflammation to the lung itself, it causes inflammation to the interstitial space around the lungs. Therefore, it has the same effects occur. The diffusion of gases is reduced, but this is mostly caused by your viruses, where the inflammation gets in, moves into the actual space surrounding the interstitial, and then causes inflammation from there. So it actually causes a cellular destruction outside the alveoli, or on the base membrane of the alveoli itself. Now, you still get dyspnea, a reduction in gaseous, but in a lot of cases, when it's chronic interstitial pneumonia, is you will actually get fibrosis, and fibrosis plaques building up on the outside of the alveoli to do with the destruction of that area itself. Now, the reason pneumonia is really looked out for, and especially in hospitals, it's a very common secondary infection in hospitals because of a lot of stagnant sitting, no deep breathing, that sort of thing, is you can get a number of different complications depending on what type of pneumonia it is and the host that actually infects. So pleural fibrosis is where we actually get fibrous scar tissue fusing the pleural space and the lungs together, so expansion is no longer viable for that area. You can get emphysema. This is mostly associated with bacterial or protozoa, because the macrophages and lymphocytes will actually eat the invading bodies, link through those pores or cones, and you'll have a large pussy growth at your base of your pleural space itself. Now, abscesses can occur, just pockets of infection causing an abscess. Bronchial excess can occur because that entire bronchus gets hard and inflamed so much that it's no longer viable, and that part of the area actually no longer inflates as well. Interstitial fibrosis is similar to your pleural, except it makes that area of the lung unable to expand when you're actually going through ventilation. And cysts, similar to abscess, they're just pockets of infections that cause a lot more necrotic type damage. So pneumonia, you definitely will see it. Just realise there's lots of different causes and some pretty bad complications that can occur from it. The next one, tuberculosis. We were under the impression a few years ago that tuberculosis was a dying, dormant sort of disorder, but it's coming back in countries that we never saw tuberculosis before. So it's one of those very, very tricky ones and very uniquely cool ones as well, as far as infectious states go too. So tuberculosis is caused by your mycobacterial tuberculosis. Okay, it makes it nice and easy to remember what it causes. And what happens is that's inhaled. Now, you'll go through different sorts of infectious states with tuberculosis. After the droplet has been inhaled, it will actually start colonizing the lung tissue. Now, most of the time, the host immune response comes along, and in the primary infection, it creates a massive capsule around it, okay, called your Gons complex. Okay, and that capsule is surrounded by lymphocytes, macrophages, neutrophils, and it creates this huge capsule. And what happens is you actually end up with this central caseous necrosis, which is a way of saying it's dead tissue that looks like cheese, so it's got all holes and everything through it. Now, because tuberculosis is such a strong and resilient bacteria, sometimes that bacteria in the middle can actually live and survive inside that capsule and wait for years and years and years. And if at any stage the immune system of the host actually drops, then it can reactivate and you can get what's known as secondary infection. Okay, so you can test positive, be 100% asymptomatic, and most of the time your primary infection you are asymptomatic, but then something happens, you get a little bit immunocompromised, and you can get a secondary infection where it spreads. Now this Gons complex can actually cause destruction to the lung. So on x-rays, you'll have a look at the x-ray and you'll actually see these rings, okay, these circles within the x-rays. You'll see the complexes themselves. And when it gets to secondary infection, it can spread throughout the lungs, completely all over the lungs, causing more host or more primary infections, if you will, or it can move to the extrapulmonary sites as well. So it can go via the blood or the lymphatic system. And when it does that, okay, it's not only affecting the lungs, like the pleural space or the other lung and moving around there, it can move to the brain and cause tuberculosis-based meningitis, tuberculosis of the urinary tract, and it can even spread to the bones, causing problems in there as well. So it's quite a nasty disease. And when you're in your secondary stage, it's spread by droplets. So you coughing, which you will do, will spread the tuberculosis, and you may be completely unaware that you even have it, because in its primary stage, it's completely asymptomatic. This is why in the military, you go to areas of high tuberculosis epidemic or working with populations that have it, you will be tested for tuberculosis, because you could feel 100% fine and then end up being a carrier of that tuberculosis to spread later on. Okay, so that's your infectious lungs disease. So we'll move on to more of your obstructive based lungs. Now these ones are characterized by obstruction, believe it or not, thank God you're sitting down, and impaired ventilation. Now they result in a excessive mucus, excessive muscle contraction, and they can be caused by a combination of those two or a tumorous growth in there. Now the classic ones that you will find is your chronic bronchitis, your emphysema, and your asthma. Now asthma is a little bit of a tricky one because it 100% is an obstructive one, but unlike the other two, it's more reversible. So it's reversible obstructive disorder. So one thing that can occur mostly from chronic bronchitis and emphysema, now not solely, there's a lot of debate with COPD. Okay, it can be caused by a number of other conditions. Chronic asthma has been thrown in there as well. Legionnaire. They've even started throwing causes that causes your pneumonitis in your cases of COPD. So it's not quite unique, but the classic ones are chronic bronchitis and emphysema. But the tricky thing about it is once you get told you have COPD, it essentially means that irreversible damage has occurred and your likelihood of getting better isn't there. So you're no longer better. So when you can get better, it's called asthma, bronchitis, something like that. When you can't, they move into COPD. Now, it's a spectrum of disorders. A lot of the times you will have signs of chronic bronchitis and emphysema together. One will sort of favour over the other. But what is 100% linked is it is associated with either smoking or the inhalation of gaseous-based chemicals themselves. So the first one we'll look at is your chronic bronchitis. So chronic bronchitis, it can be clinically defined as a chronically productive cough for most of the day for at least 3 months, and then over 2 or 3 consecutive years. Okay, so to get chronic bronchitis, you have to have this pattern emerging. If you don't, there's bronchitis. Chronic, that's the definition. Now, it's mostly caused by smoking, as I mentioned, and what happens is as you constantly get irritated by the smoke, your bronchi and bronchioles gets inflamed. Now, what happens there is it causes your mucus glands that we spoke about at the start of the lecture to actually increase in number and increase in size, therefore produce a hell of a lot more mucus itself. You also go through a phase called metaplastic formations of the goblet cells. Now what that means is your epithelial layer on the inside will actually grossly change themselves. So actually producing more dysfunctional cellular structures on the inside of the lung, so reducing the lumen even further. You'll also get chronic inflammation and fibrosis of your bronchial walls. As a result of all these things, you have more cells, more dysfunctional cells, and bigger cells all producing mucus, so you end up with this huge amount of mucus state. And at the same time, you get an overall narrowing of the airways themselves. Now with that narrowing of the airways and this chronic inflammatory state, what can happen is you'll end up getting scarring or fibrosis occurring of the pulmonary capillaries. Now what that causes, because you've got scarring, they're no longer flexible, they usually reduce in size, is you end up with what's known as pulmonary hypertension. So you'll get focused hypertension of your pulmonary arteries as a result. Now this pulmonary hypertension causes a unique case of an increased afterload, but this time to the right side of the heart. So remember in the last lecture we spoke that most of the time afterload is associated with the left side of the heart failure, and the left side of the heart failure is more associated with causing problems in the lungs. Well, in the case of chronic bronchitis, you get pulmonary hypertension of those capillaries surrounding the lungs, which is fed by the right side of the heart and the pulmonary arteries, which causes an afterload, increased afterload, so you actually end up getting right-sided heart failure, known as a special one, which is your cor pulmonae, cor pulmonae, and that is a special type of right-sided heart failure caused by your chronic bronchitis. Now the other classic one to look at is your emphysema. Now this one is defined as irreversible destruction of your alveoli, and this is associated with overinflation of the lungs. So because of the destruction of your alveoli, it actually turns into big bowls instead of nice little grapes, and you end up having a massive overinflation of your lungs. Now the pathophysiology to emphysema is pretty cool. It can pretty much be linked to an enzyme called alpha-1 antitrypsin. And emphysema occurs when there's a deficiency in this particular enzyme. Now that can happen one or two ways. It can either happen by the presence of free radicals. Okay, so smoking will actually inactivate the enzyme, or you can have a congenital defect. Now what this enzyme does is, in the presence of neutrophils, so neutrophils will come in and they'll produce a condition known as neutrophil electase. Now what that does is it breaks down elastic-based tissue. Now in the presence of this enzyme, it produces a protease. Now protease itself will protect the lungs from this neutrophil destructive presence, and that's what it does. Okay, so in the absence of this, because of smoking or a congenital defect, when the neutrophils come in as a result of inflammation, they will actually cause tissue damage to the alveoli. So it's the presence of smoking that is actually stopping the neutrophil activity from destroying the alveoli as well as the bacteria. Now the difference is the neutrophils don't realise that it doesn't have to be an infectious state. As soon as inflammatory response comes in, neutrophils are drawn to it as a chemotaxis. They will be drawn to the alveoli and they will do their thing. Now in the form of this inflammation, it will lead to scarring and thickening of the airway. So when that happens, the chronic inflammation will cause tissues damage as well. Now that will reduce the surface area available for gaseous exchange, resulting in metamorphosis needing to occur or changes needing to occur. So the alveoli reaches out and blows up, trying to get greater surface area in order to have some form of gaseous exchange. Looking at the differences in your clinical features for these two, for COPD patients, we have the bronchitis based, which are known as your blue bloaters, and your emphysema based, which are your pink puffers. Now the difference is when we look at the chest, with bronchitis, your chest appears normal because there's no increased size as far as ventilation volume goes. Whereas the other side of the fence, emphysema, you can usually get a big barrel chest. Now, both of them are associated with dyspnea. Okay, but your pink puffers, because you're a CO2 retainer, you're trying to breathe out a lot more. Remember, CO2 has a much greater affinity at causing respiratory drive, so you have greater need for that one. To breathe, therefore you have greater dyspnea with emphysema. Coughing is the opposite. In emphysema patients, you cough as a result of trying to clear something. There's not much there to clear. You want to blow off excess CO2, get that pressure in the lungs. Whereas in bronchitis, you're actually coughing up a bunch of sputum. So emphysema can be plus or minus sputum. Bronchitis, always sputum. Bronchitis is associated with pulmonary hypertension and peripheral edema because of the right side of the heart failure. Right side of the heart failure caused by pulmonary hypertension will have a secondary effect of your pulmonary edema. Okay, and that's what you get. So there's the differences in the comparison between the two classic causes of COPD. Now, quickly looking at asthma, we focus on it a lot. Asthma is a little bit different. It is obstructive, but it's chronic inflammation disease that is reversible. Okay, it is caused by widespread sort of problems. So as far as the triggering factors go, that can be either an extrinsic factor, which is usually associated with allergies. So an allergy will come in and cause this inflammatory response. Or it can even be caused by intrinsic factors, okay, so non-allergic base. Now this can be exercise, stress, cold weather, irritants, bronchial infections, certain drugs like aspirin. They can all bring on these intrinsic asthma sort of effects. Now what happens is you end up with airway inflammation. So your airways will actually inflame. As a result of that, you get a constriction of the muscles, a huge amount of mucus being produced, and your bronchial membrane will spread. Now that narrows your breathing, causes wheezing, coughing, shortness of breath, and tightness in the chest. So asthmatics will often complain of the inability to get air out. Now when we look at it at a cellular level, we can see the four structures that are affected by this. So your first one is mucus pouring into the lumen of the actual bronchus. So that's going to reduce the size altogether, and if it goes down, it's going to reduce the ability for gaseous exchange and obviously create a plug as the expiration happens, and it's going to trap air in the base as well. The base membrane itself gets inflamed because of inflammation, so naturally it will become inflamed. Your glands will enlarge because of this inflammation, producing more mucus as well. And your smooth muscles over time will actually go through hyperplasia, so they'll increase in mass and numbers as a result of this chronic state in order to compensate for this attack that they're feeling. Now, wheezing is very, very specific to this because it can be mistaken with certain types of pulmonary oedema. So you want to have a good listen to the chest, listening for wheezing. And you want to have a look at the position they're in and the way that they're breathing. Now if they cough, The cough is generally just a clear-based substance, but a lot of the times with acute asthma attacks you won't see it. It's only when chronic asthmatics who are always affected, you'll start getting this, a lot of irritants build up pretty much all the time. So from obstructive, we move to restrictive lung disease. Now the difference with these is these are characterized by the inability for the lungs to expand as a result of lost elasticity. So because they've lost that elasticity, when you breathe, it only has a certain amount that can breathe. Now these, unlike the other ones, like infections, things like that, this is chronic fibrosis, so chronic scar tissue occurring throughout the lungs. Now this is your irreversible. So it doesn't matter how many stem cells there are in the lungs to repair during infection, these particular ones will actually cause scar tissue through the lungs, meaning that that area is no longer viable. Now there are many types of restrictive pulmonary diseases, but the two of them can be classified, two main ones that encompass a lot of them, is your hypersensitivity pneumonitis and your pneumoconiosis. Geez, it's a tough one to say. Pneumoconiosis. Now, both of them have the same characteristics. Okay, so both of them cause pulmonary fibrosis, so scar tissue of the actual lungs themselves. The difference is what the causative agent is. So hypersensitivity pneumonitis is caused by organic dust, meaning coming from plant products, coming from feces, animal furs, stuff like that. Okay, whereas your pneumoconiosis is caused by the breathing in of inorganic dusts. Now these can be heavy metals, your coal, your cilia, and your asbestos, as well as a bunch of heavy metals will cause this particular one. Now the difference is it's not associated with smoking. These ones aren't, but smoking definitely complicates both of these conditions. Most of the times these are diagnosed as irreversible cause, an irreversible state that is related to people's work. And there is a massive chance of these particular disorders causing malignancies, okay, so turning into your cancers. At this stage, none of them actually have cures. So some of your classic ones is your coal workers' lungs and asbestosis. Okay, they're very classic ones. And when you look at the autopsies, you'll actually see the discoloration in the lungs, as well as a whole bunch of scar tissue. Now the clinical signs, as you'd expect, because there's a whole bunch of fibrosis in the lungs, you have a cough because of this constant irritant and mucus build-up, but then as it progresses into malignancy, it goes from your simple dyspnea and your coughing into fever, weight loss, and general fatigue as well, because obviously malignancies or lung cancers themselves can spread pretty easily around the rest of the body. Now this picture pretty much illustrates what happens in most of the cases. The difference is this one is just focusing on asbestos, but similar pathophysiology occurs for any one of these. It's got to do with some form of fibre or dust coming into the lung. Now the difference is there's either too many for the macrophages to break down, or the macrophages cannot break it down. They just cannot destroy it. So they'll come in, the macrophage will try to eat it, won't be able to, it will just be spat out completely through phagocytosis, and it will form its own special body. Now this body causes a huge amount of inflammation and sustained inflammation. It doesn't go anywhere over time. So that means that the cellular structures, internal and external, so inside the alveoli and in the interstitial space, turn into fibrosis. Okay, the asbestos or anything else, the other dust will move through these pores or cones, and they'll come into it, and they'll cause massive fibrosis, including fibrosis plaques. And there's also a chance of lung cancer, which we'll talk about soon, and your mesothelioma as well of your base membrane. So that is basically a massive case of dysphasic growth or metaphasic growth within the area, which can easily be turned into your cancerous growth, or a very benign growth mass as well as your lung cancer. So that's what a lot of these classic restrictive lung diseases can cause. So the main way to do it, because there is no cure for these, is a lot of the time education on these things, so we avoid contact with these substances. There's a bunch of unique ones in the military, so composite fibers from aeroplane crashes and chopper crashes is a very classic one. They're usually dampened down by water, therefore you don't breathe them in. Heavy metals, as I mentioned. So education's coming out a lot, and the encouragement of using PPE is more enforced now than it used to be, meaning a lot of these disorders shouldn't be as prevalent in the future. Now, ventilatory disturbances are associated with a inability for your lungs to fully expand, okay, or a reduction in the amount in which your lungs expand. So they're fully classified as your atelectasis. Now this is just defined as collapsing of the alveoli. Okay, so that can happen for a number of reasons we'll talk about. So when we're dealing with the little farts, the neonates, it's often associated with surfactant deficiencies, especially in premature babies. Okay, you can also have compression, collapse, or reabsorption of air around the actual lungs because of an obstruction or a tumorous growth. Okay, so the lung doesn't get to that particular area. Okay, so in the case of a collapse, it's mostly associated with your pneumothorax, either opened or spontaneous. Now, open pneumothorax is obvious, opening to the chest wall. Spontaneous can be idiopathic, can be caused by emphysema, or it can be caused by blast trauma as well, as we all know. Okay, so that's your pneumothoraces. We won't talk too much about that. The other one is your hydrothorax. So this is where fluid will build up in the actual pleural space, or in the thorax itself, and that is your pleural effusion, things like that. Now, obstructive is when we start looking at our tumour. So tumour will block an actual area, so cellular growth will block an area of the bronchi, meaning every time you take a breath in, that particular aspect of the lung doesn't get filled, therefore it's a ventilatory disturbance. Now, another type of ventilatory disturbance or disease is your acute respiratory distress syndrome. Now, this is just defined as a change that occurs in the lungs as a result of a lung injury. Okay, so once you get an injury, then acute respiratory distress syndrome kicks in. Now, the causes can be sepsis, internal, so you get internal lung injury. Near drowning is a classic one. Smoke, certain chemical inhalation, noxious gas, aspiration of fluid, food, whatever, and let's see, irradiation as well. Anything that destroys the base membrane basically can occur. So what happens in these particular cases is we have a destruction to the cellular side of the house. So there's an acute injury causing cellular damage. Now this can either be to the lining of the alveoli or the endothelial wall of the capillaries in the case of sepsis. Now what happens in that particular case is it forms a new membrane. Okay, a new membrane is formed in between, so it interrupts the pneumocyte type 1, or it interrupts the gaseous exchange with the capillaries, and we end up with a hyaline membrane that blocks it itself. And now this encourages more leukocytes to come to the area. It causes a hole in the actual capillary walls, which results in a form of pulmonary oedema as well. So the vessels themselves become leaky because the cellular structure has moved apart as a result of this inflammation and formation of fibrous lung tissue, if you will, and that makes it viable for fluid to leak out. So you get a further reduction in gaseous exchange. Okay, so that's your acute respiratory distress syndrome. When you ever hear that one, that's what it means. It can either be destruction to lung injury from the lungs or to the capillaries themselves. The end result is pretty much the same, but sometimes you can end up with dual layer, both membrane of lungs and endothelial cell injury as well. Okay, looking quickly at your neoplasmic formations is we'll look at lung cancer, very common types, mostly associated with cigarettes and those restrictive lung disease, so the breathing in of asbestos, coal, uranium. It can also be from a substance called radon, and radon is found in rocks. So any quarry workers busting rocks can get radon exposure as well. So what happens when we're dealing with lung cancer is we get our normal cellular structures, and then all of a sudden, because of the presence of these substances, we end up getting DNA changes. Now, DNA changes basically means that they're no longer controlled by any rule. Now, we talked about this during the neoplastic lesson of this particular one, but just to bring it into lung case, DNA means they're not subject to normal rules. So they don't have the same shelf life, they don't have the same formation, so they can end up with a metaplasia formation. So that means they'll just keep growing in a different formation and they'll rapidly grow as well. Okay, on top of that, we can have certain growths, so your angiocarcinomas are associated with your cellular structures that release endocrine-based hormones that are not associated with the endocrine system. So that can happen within the lungs as well. Now, when you get this chronic irritation and you get this metaplasia as a result of the need to rapidly adapt, then most of the time that's asymptomatic. It doesn't really affect the gaseous exchange, that sort of thing. You don't really have dyspnea or anything like that. So they'll just basically say, I don't have the exposure, so I don't have to stop smoking. Then people will keep smoking, and then all of a sudden this metaplasia will turn into a squamous cell carcinoma or dysplasia, and that's where it becomes dangerous. That's when it starts metastasizing around the body, around the lungs, and starts spreading everywhere. Now with that, you'll end up with a lot more symptoms. As soon as it interferes with the alveoli, you'll start getting this dyspnea. With certain cellular growths, it can produce more mucus, so you can get coughing, and you can end up with stridor or even wheezing sometimes because of the mass that you find in there. If it gets into the dysplasia side of the house, then you can get hemoptysis as well. Now, once it gets metastasized, then you'll have all your systemic problems from there. Okay, so metastasize, depending where it goes from the lungs, obviously it can go anywhere. Okay, it is the most common malignant tumour of the lungs is your metastasis of the lungs. And they may present as multiple lesions throughout all over the lungs, diffused all over the lungs, or it may just be in a simple area as well. But what that means is it can spread throughout the body. Your brain, your liver, your kidney, bones, heart, doesn't matter, it just spreads throughout your body from there. So it can be quite dangerous. Now, on top of that, there's also with smoking and those sort of things, you have a chance of getting cancer of your larynx as well. And that's where similar problems, you get your dyspnea and stridor, very sore vibrations of the throat, but you also get your hoarseness in your voice as well. Okay, moving on, we'll just look at some pleural diseases. So we've already looked at our pneumothorax, that's the air in the space. Now hydrothorax we already talked about, that's your pleural effusion. That's where fluid will actually pull out of the lungs and then sit within the pleural space. Okay, it's obviously often needed to be drained out of there. Now emphysema we've spoken about, that's chronic infection where pus will actually pull in the base of the pleural space and cause an ineffectiveness of that pleural space, and then a reduction in your actual oxygenation. Now pleurisitis is inflammation of the pleura itself. That's often accompanied by an increase in fluid. Now fibrothorax is when you get a fibrous scar tissue that connects the lung to the pleural space. And your mesothelioma, that's neoplasmic formation that's caused mostly by asbestos that we looked at, how it spreads into the pleural space, making a gap, and therefore making it more likely to get things like pneumothoraxes and a reduction in actual blood flow. The The last thing we'll look at is the disorders associated with your pulmonary vascular diseases. So the first one, probably the most common actually of all your pulmonary vascular diseases, is pulmonary emboli. Now these often derive from embolus, from deep vein thrombosis. Now remember before we spoke about emboli and how they're formed, we have certain risk factors called the Valcal triad that are needed in order to increase the risk of emboli. So that is stasis, so static blood, endothelial wall damage, which is probably the biggest risk factor associated with the Valcal's triad, and then you can also have your hypercoagulopathic state. Now what happens with this pulmonary embolism is it can travel from around the body, and because all veins will travel to the heart, you can go from the heart, nice big vessels, but then it starts getting to smaller vessels, okay, and it moves into the lungs itself. So from there it branches into the actual lungs, where the divisions get smaller, and you can either get a massive embolus, which blocks the full pulmonary artery, and that not only does it cut off the lung, but it cuts off the blood supply. You get secondary heart failure, overload, congestive, and you'll end up with pretty emergency state problem. If it's a little bit smaller, then you'll end up with part of the lungs actually dying. Other things that can happen is you can get really small emboli that will move around the actual area, and that will cause your pulmonary hypertension, and from there you'll get the same effects of pulmonary hypertension that we spoke about before. Okay, you end up with right side heart failure, and then peripheral edema, similar to your chronic bronchitis as well. Okay, so that's your pulmonary embolus, an absolute medical emergency. We can spend a whole day talking on the emergency side of the house, but it's more of an introduction, this lesson is. Okay, and the last one we'll look at is your pulmonary edema. Now this is quite a difficult one because it has so many causes. So pulmonary edema is just fluid in the alveoli space. Now classically it has cardiogenic association. So cardiogenic pulmonary edema is associated with hypertension, left ventricle failure, and any form of cardiomyopathy. They're your very classic ones. Ones that often get overlooked is your non-cardiogenic. So what happens a lot of the times in these is you either have a destruction of the base membrane, or you have a substance in the lungs that draws fluid itself. Okay. The other way it can happen is with reduced oxygenation. So reduction in oxygenation and breathing rates can actually cause pulmonary edema because the pressure in the base is released. Therefore, just purely through hydrostatic pressure gradients, fluid will move into it. Okay, so classic non-cardiogenic causes is breathing in, breathing in any substances. So near drowning, gastric contents, smoke, anything like that, irritations, burns, that can all cause this pulmonary edema. Sepsis can because of profound vasodilation. Profound vasodilation with a reduction in interthoracic pressure is going to cause it. That's where pneumonia comes in as well, and also malignant growth. Malignant growth can bridge the gap between fluid and your lungs itself, sort of like your acute respiratory distress syndrome, but all over. Pancreatitis and things like that, that's got to do with a hell of a lot of transitional fluid shifts. So now we have an increase in fluid in the interstitial space, making a massive hydrostatic pressure on the pulmonary capillaries and then into the lungs itself. When we move into head injuries, that's associated with a reduction in actual ventilated volume, doing the same thing. Okay, so that's your pulmonary edema. It can be chronic, or in a lot of cases, when we're dealing with the non-cardiogenic ones, it's quite an acute state of pulmonary edema. Still needs to be looked after. Okay, that ends respiratory pathophysiology. I hope you found it interesting and got something out of it. We'll keep